I'm delighted to be here with today's guest, Ifeanyi Nsofor, a public health physician, behavioural science researcher, and global health equity advocate. He has over 130 published articles and has led over 30 research projects across West Africa. He's recognised as one of the top 100 most influential Africans in 2020 and played a key role in evaluating the African Union's response to the Ebola outbreak. He's a member of the Global Fellows Advisory Board at the Atlantic Institution, Rhodes Trust, Oxford. Ifeanyi is currently the director of a project that uses social media and community pharmacists to increase HPV vaccine uptake in Nigeria. I'm delighted to be your host for today. My name's Laura Dean. I'm a reader in social science and global health at LSTM, and hopefully will guide us through an exciting conversation with Ifeanyi. So Ifeanyi, perhaps we could start with asking you what inspired you to pursue a career in global health and public health advocacy, and how did LSTM shape your journey?
All right, thanks, Laura. It's really a pleasure to be part of this. LSTM holds a very important place in my life because I think a lot of what I do today was shaped by LSTM in 2007. That's a long time ago. So interestingly, I left medical school in 1998. When I left medical school, I wanted to be a plastic and reconstructive surgeon. Right. And in Nigeria, when you leave medical school, you have 1 year of internship within the hospital so that you're trained further before your final license. And then you now do your national youth service, another year where you serve the government, usually in different locations across the country. So I did my national youth service with the Nigerian Army in Abuja, the nation's capital. And I remember that, that was really a turning point for me as a young doctor, because I saw lots of the cases I saw in the clinics were really preventable. You would see a mother will rush her child, febrile, in shock, anemic, and all. And most times you would save the child, transfuse the child and ensure that the child survives. But in a few times you lost them. And for me, it got me thinking then that maybe I'm really not suited for this clinical work. I'd rather work more in preventing people from falling ill. Because in my mind's eye then, it made more sense. It was more cost effective. And that was when I decided, I abandoned my plastic and reconstructive surgery, and for me then it was community health, public health, global health, whatever you choose to call it. And I was lucky to have gotten a Ford Foundation International Fellowship that paid for my master's at the Liverpool School of Tropical Medicine. So that was how I segued into public health, public health advocacy, research and all, because I really felt, and I still feel, that we need to prevent people from falling sick, because apart from the costs, the finances of taking care of illnesses, it also costs a lot in terms of morbidity and illness and ill health, to people, essentially. Yeah. So that's how I found myself in this track.
Thank you. It's really nice to hear about your passion for the social drivers of health and why it's important that we address those in preventing people from falling ill. And I know that's at the heart of much of the community health systems work we do here at LSTM, and part of the master's program that you undertook. Linked to the social drivers of health, you've been really vocal in your career about combating health misinformation. And could you share with us a little bit more about the strategies that you've seen to be most effective when tackling misinformation in public and global health?
In 2019, this was after several years of working in global health, I became a fellow, an Atlantic Fellow for Health Equity. And part of the fellowship here was, an executive course on health equity at the University of Global Health Equity in Rwanda. And I'm telling this story because when I walked into the class, when we got to the Butaro campus in Rwanda, I saw a mural on the wall. It was a writing, and it says, to achieve equity in healthcare, we have to achieve equity in health education. So for me, when I saw that particular quote, it was like a reaffirmation of everything I had done before to improve knowledge of, health education, improving people's knowledge about what to do, what not to do to improve health. Because ultimately, the first step in changing people's behaviors for good is for them to know. For them to get the right information through different channels. Ultimately, and also get that information in such an empathetic way that they would see, the value in it for them and be able to, prioritize health for themselves and for their families. And for me, this was really something that has shaped, the way that I do the work that I do, because it's all about information. And when you think about it, the people who are putting out the wrong information also know the importance of what they do. But if I may speak briefly to public health advocates like myself, through all these years, I've also found out a way of framing my public health advocacy in such a way that it's easy for me to articulate my thoughts. So, for instance, I say, what's the problem? You define what the problem is. What are the solutions to that problem? Then what are the calls to action? And the calls to action is what you want people to do. And it will depend on who it is you're talking to. If you're addressing a particular health issue and you're talking to, say, program managers, the calls to action would differ from, if you're talking to a woman in the village or the traditional leadership. But to me, everything really boils down on what you know, getting the right information, getting those information through the right channels and at the right time, and also consistently, at the long run, it helps you change behaviors.
Thank you. I think that's important in terms of information being powerful, but also the right information for the right people at the right times. Perhaps you could talk a little bit more about how you think technology and digital platforms can be useful in further driving kind of the sharing of public health information and countering misinformation.
Oh, I mean, we live in the technology age. I think any public health advocacy campaign that does not embrace the power of technology is really, in a way, in today's world, it doesn't matter where the people are located. It's really doomed to fail, to be honest. So the question is, what technological platforms exist or have the most usage where it is that you're located? And, we can't talk about technology for public health advocacy without mentioning social media. And I know that for people like us who work in the public health space, some people, people are like divided. I don't want to get engaged with social media, while others say that we should engage with social media. But I like what an American tech entrepreneur said, Eric Coleman. He said, it is no longer whether we should do social media, but how well we do it. So it's understanding that, you have more than 3 billion people across different social media platforms. And so that is where people live. Even in places like Nigeria, for instance, probably close to 50 million Nigerians, about 25% of our population, are on Facebook and Instagram. So you cannot ignore it, because this is where people, live, interact, trade and all. But also, let's not forget other technologies. So, for instance, TV, radio, podcasts like this. I mean, there are different ways. So for me, in summary, in today's world, we really need to tap into technology. But ultimately, to me, the most influential technology as of today is social media. And I want to see more people like myself use social media for good, putting out the right information and, as much as possible, countering those wrong information that people who the mischief makers put out on a regular basis.
Thank you. I agree with you. I guess I wondered if you could talk a bit more about your experiences of the use of information and science communication and tackling misinformation when you were involved in the Ebola response in West Africa, because obviously that was a huge challenge and something that had to be overcome in populations where access to technology and digital platforms is quite inequitable in itself. And so I just wondered what your experience has been in those type of contexts or in public health crises where a response and information is needed, but obviously there's a lot of misinformation circulating at the same time.
Years ago, I was the director of policy and advocacy with Nigeria Health Watch, which is really Nigeria's leading public health nonprofit, that puts out information to the public. One thing that we did was we tried to put out information in different ways. So, for instance, radio was a very important way that we put out information because in Nigeria, especially in northern Nigeria, we are based in Abuja, but most radio stations now can transmit across, different regions. So radio was very important. Sometimes we'll create different radio shows, go to different radio stations, talk about it. People have we have calling programs, people can call and ask questions. But we also did, vox pops. We will send some of our colleagues to the street and ask people questions about health. The idea is to just unpack what people think about different health issues, then come back, edit it, in our studio, and now put out that, small snippets of what people said, whether it was right or wrong, and now, help people understand the best way to address those health issues. One other thing that we did then was, we had this project we did at every election in Nigeria. We called it Vote for Health Niger, because for us we had consistently advocated that for healthcare to change in Nigeria, we need active citizenship for health. Mm-hmm. So people need to understand that health matters, and if it matters to them, then they can begin to hold elected representatives, even before they're elected, accountable, to say, what are you going to do about our healthcare? So we had, Vote for Health Niger. But also for me as a thought leader, having written all these articles, for me, it has become a very important way of putting out information, especially opinion articles. Yeah, of course, I also publish in peer-reviewed journals, but over the years, I've come to realize that when you publish opinion articles, for instance, it's easier for people to understand what it is you're talking about. Because you write in such a way that you break down very complex health issues for people to understand. And I remember even Liverpool, LSTM used to have, I don't know if it's still in existence, this evidence update, where you summarize Cochrane, publications that are usually 50 pages, summarize them into 2 pages, in formats that policymakers, program managers can understand. So for me, I've really approached this, through different ways. And the beauty of it is that what works in one place may not work in the other place. But it is really looking at the population that you're primarily interested in and saying, what's the low-hanging fruit here? What will work the most? If you're addressing issues that affect young people, surely social media. Sometimes even when I work with Nigeria Health Watch, we would go to communities and really go around, and talk to people face to face, have small rallies where people can come together and even help moderate some community conversations, because in those communities, those were the things that worked best for them. And for me, I think it's very important tapping into those things that work best in different communities.
I suppose it would be really nice, I guess, to hear your reflections around lessons you have for academics, researchers, scientists who are working at that kind of interface where they're working a lot with communities and then trying to support that accountability within the health system so that decision makers or program managers, as you're saying, kind of act on the findings or the information or things that are being produced within research or the kind of everyday realities of communities. Yeah. And I guess from your experience, it would be really nice to hear about what you think some of the challenges are for researchers and scientists when they're communicating their work, and how do we ensure that we don't unintentionally feed into some of these kind of misinformation debates or things that are happening.
Okay, so I think for researchers, academics, really interested in producing strong evidence, publishing articles to help advance their careers and all. But to me, it is also understanding that when an evidence is generated in a particular place, we also need to break it down for the local people to understand what it is we're talking about. Because I think most times, when scientists talk about different issues. They really use very, big, highfalutin words, for lack of a better expression. They use a lot of jargon that people don't understand. And if people don't understand what it is you're talking about, it's almost as if you've not spoken to them, right? So, and if I go back to what I said initially about problem, what I consider as a formula for health advocacy, what is the problem, what are the solutions, and what are the calls to action? So even when you have generated evidence in a particular location, so these are the different problems. So for this particular community, these are the solutions, to addressing your issues. But for the different demographics in those communities, these are the different ways you can be part of those solutions, which for me is what the calls to action really mean. If I go back to the work we did evaluating the African Union's support to end Ebola in West Africa, we traveled across Guinea, Liberia, and Sierra Leone within a 2-week period. Interviewing African Union volunteers, international partners, community members, ministries of health, different stakeholders, interviewing them. And at the end of the day, we produced a report for the African Union to say, these are the ways that the African Union volunteers were game changers for this. And going forward, if we're going to stop such epidemics from happening and overwhelming our health system, these are the things we ought to do. And interestingly, when we did that research, the Africa CDC was not in existence. So one of our recommendations was actually establishing an Africa CDC under the African Union to take charge of infectious disease prevention, detection, and response across the continent. So to me, in summary, it's really, we need to break down to people. And I feel that scientists, academics should also not just focus only publishing in peer-reviewed articles, because you see, you are the experts. People, you already have a lot of respect, across the board. People respect you, people want to listen to you. And when you publish in only peer-reviewed journals, it's almost like we're just talking to ourselves, because how many people outside the academic community get to read those articles? So I would like to see scientists write more of opinion articles, commentaries, go on radio shows, go on TV, be active on social media. And I'm happy to see that more scientists are beginning to really do that. But we really need to do more of that, so that ultimately, beyond generating evidence and promoting our careers, but really helping our communities understand in very simple forms what the issues are and how they can address them.
And one of the things that I think we're really passionate about in LSTM at the moment is around how we can support, I guess, African scientists and African voices or other voices from within our LMIC partners to have equal weighting, I suppose, on the kind of world stage in terms of priorities and knowledge sharing and tackling misinformation. And obviously you were part of recommending the establishment of the Africa CDC, which has been a great step towards that. And so I guess I just wanted to understand more about your opinions and how we can be allies in LSTM in supporting the kind of dominance of information generation and sharing to shift from the global north to the global south, or to countries that historically have had less of a prominence on that kind of stage in terms of what's listened to, I suppose.
I also speak and write a lot on decolonizing global health.
Yeah.
I'm happy that the movement is picking up, but I think that we should use knowledge wherever it is generated. So I'd like to see more of, knowledge transfer from the global south to the global north, and that can happen in different ways. Of course, LSTM on its own is also a leader in this space, because over the years, LSTM has really had very great partnerships with different countries, ministries of health in the global south. But get more people who are on the ground. I mean, from the work that I've done traveling across different African countries, you get to communities and you see, they don't have very fancy titles. They've not traveled to very fancy places. But these are the people who are the game changers, who are doing all the work, to really change, health systems where they are located. So, for instance, I think, what happens in Rwanda, the community health worker system in Rwanda, that is really the bedrock of the Rwandan health system. It's something that I think the global community needs to get to know more about. So, for instance, when LSTM hosts meetings, for instance, it's not just the very big professors that should be invited. People who are on the ground, people who are applying very basic solutions that save lives. Is the day-to-day thing that they do in their communities. I think that's really important. And again, I keep going back to social media because it's such a very powerful space. It will also be good for LSTM to tap into the alumni network and get to, profile more alumni on social media. You may be having, tweet chats. You may be having Instagram Live. It may just be, getting information from people about the work that they are doing and how they are saving lives, especially for people from the global south, and help profile that. Because the more that happens, the more those individuals are established as thought leaders in their own right, and the more they gain prominence and probably also get other recognitions to come and share the work that they do. When I don't know if it still happens in LSTM, but when I was there, I had to go to Zambia for my research. I went to Zambia. A number of my classmates went to different places, and it was a life changer for me because although I'm African, but I hadn't been to Zambia. In fact, then I hadn't been to Southern Africa at all. But I was there for 8 weeks, did my research in HIV, and by the time I got back to LSTM, I decided to also be a research client to the school. When I went back to Nigeria for a period of 3 years, students from LSTM, 3 different students, came to do their own research in Nigeria in different, areas of health. So even the existing student community within LSTM, I think there is a very important resource because a number of people who leave the global south for masters or PhD really have huge experiences doing this work. So it will also be good to get some of those, students who are already in campus, to really get to hear about the work that they do and profile that work. But ultimately, LSTM has to be a leader, in decolonizing global health. LSTM itself acknowledges that, its history is really, dipped in, slavery and colonialism, and that's fine. But in trying to address that, I think, LSTM should, continue to engage with people from the global south and profiling them. And when LSTM leadership are on different tables where people are required for leadership, also try to recommend leaders from the global south because people have great experiences.
Thank you. I completely agree with you, and I think we do recognize our kind of colonial history in LSTM, and we are really trying to address that, but it has to be addressed in collaboration with people like yourself and the game changers at the grassroots level that you've reminded us about, and how we support to amplify those voices and change those power hierarchies is really important. You've talked a lot about your time at LSTM and shared some memories, and I know certainly from my time as a student at LSTM, the kind of collegial relationships and the learning from each other as students is really important. But I wondered if you could just reflect for us a little bit about your fondest memories of your time at LSTM and how the education and network that you gained through LSTM has impacted your professional work so far.
So, coming to LSTM was really, when I look back, a very important decision. As a Ford Foundation Fellow, I had the options to go to the London School of Hygiene and Tropical Medicine, Queen Margaret University, Edinburgh, or LSTM. These were my 3 choices. I was supposed to choose because the British Council had done the placement on my behalf. And I remember asking the British Council officer, which one would she recommend? Of course, I was gravitating towards London School because most of my seniors in medical school went to London School. I can't remember the lady's name, but she said, go to Liverpool. And I asked why. And she said Liverpool has a great research experience. That was how I made my decision to go to Liverpool. And I've not regretted that. Because first of all, it was also my first time of being in an international space with people from different countries working together. In Nigeria, being part of the polio campaign, of course, I had people coming, international workers coming and all, but just being an academic environment with people from different countries, fellow Nigerians, Africans, people from other parts of the world, it was really fun. Um, and for me, some of my fondest memories in Liverpool was really the openness of the faculty. And coming from a place where, there was a hierarchy between you and your lecturers, you couldn't even call them by their first names and things like that. I remember when Professor Ghana, who was my academic advisor, my first academic advisor, asked me to call him Paul. I just looked at, in fact, two of us from Nigeria, one guy from Sierra Leone, we told him it's not possible. We cannot call him Paul. And he was like, why? I said, Professor Ghana, I'm Nigerian. I come from Igbo tribe. In my tribe, you're like a big masquerade. And when a big masquerade comes out, other smaller masquerades will run out, because that's how important you are. But he insisted. So for me, that informal environment, being able to engage with your lecturers, your advisors, eventually Dr. Sally Philbert became my academic advisor until I left. But just that familiarity to me was really something that shaped, what I did. I came to Liverpool as a very important doctor. I left as somebody who, who had all those, airs of importance really, removed from me. But Liverpool for me then was really fun because it's a multicultural city. It was easy to move around and see people like yourself. So it was almost like the difference between Liverpool and in Abuja, where I live, was the weather. Because it was easy for me to really integrate. I really loved going to the city center. It was almost like a daily occurrence, even if I wasn't buying anything, just going around, walking around. And with time, when I now started traveling around the UK, when I had the time, it was great going to the docks, learning about the colonial history of Liverpool and all, and just generally exploring the city. And of course, one fun challenge I had in Liverpool was struggling to understand when people speak, when the Liverpool indigenes speak. It was a lot of battle trying to understand what they were saying, but with time, I was easy to comprehend that. Yeah. So to be honest, Liverpool was the first place where that shaped my understanding of equity. I didn't know the word then for equity, but just seeing how things were done, relationship with students, when you were going for your research, the way that you were counseled on how to behave, what to do, how to respect people, the communities, they really shaped what I did. And seeing very, very, very influential faculty really come down to my level as a student, then to me it's something that I can't forget in a haste. I keep telling the stories of Professor Ghana, I'm still calling him Professor Ghana. That's how that's that's how much is ingrained in my mind.
That's really lovely to hear. And I think, as you say, that almost humility and being humble and stripping of titles is really central, certainly in my experience as well, to really supporting us to address health equity issues and to support kind of decolonization processes. And I think as a kind of resident of Liverpool, I think it speaks to the values of the city as well as LSTM as an institution. And it's really nice to hear you reflect on that. You have been a real champion of global health equity and had many achievements that have promoted better health and well-being for many people around the world, and particularly in Western and Central Africa. And I suppose I wanted to ask you a final question, really, as if you could talk to us about what you think are the most pressing steps needed to achieve health equity globally, and how do you see that changing over the next decade?
So I think for me, I'm going to quote the Gates Foundation: all lives are created equal. I think we need to really bear that in mind and practice it. Saying that is also speaking to the international global health community, that the way that Africa, for instance, is perceived is totally wrong. For some people, they look at it, once you talk about infectious diseases, what comes to mind is Africa, forgetting the great work that people do across the continent, to stop those infectious diseases from happening and all. So for me, I think so. For one is all lives are created equal. Two, we need to use knowledge, no matter where that knowledge is generated from. We need to have equal representation of leadership at the global level. Because if you look at COVID, I've written and spoken a lot about, COVID vaccine inequity and the fact that global bodies came together to make a decision for Africa without Africa being at the table. It doesn't make sense, but it's 21st century and that is still happening. So that has to change to get, Africans and people from other low and middle income countries to be part of the decision-making process. But having said all this, I think we are, on one hand, I need to see African leaders be more responsible, be more accountable to our people, governance improved, corruption, eliminated. But in doing this, we need the global north to hold African leaders accountable. Because, almost every year, every 2 years in Nigeria, you hear that certain amounts that was stolen by a politician that was held in the global north after several decades is being returned to the country. And what I ask myself is, why is that money allowed to be stolen first to the global north? So the global north has an important responsibility to hold African leaders accountable so that when those funds are coming, you have to stop, or you have to stop those funds from moving, out of Africa. The estimated, illicit financial outflows out of Africa is almost 80-something billion dollars a year that leaves the continent. What Africa gets as foreign aid is about 60-something billion dollars. And what that tells you is that if the global north is more involved in blocking those illicit financial outflows, probably will not be needing any aid from anywhere at all, because those funds will have to be used for our people. So I think that's very important. African leaders stepping up, then the global north leaders also, being part of that, so that funds are not leaving the continent and other parts of low and middle income countries. Because if we believe that all lives are created equal, then you have a situation where the UK, Canada were hoarding COVID-19 vaccines when Africa didn't have any. 3 to 5 times their population size, hoarding those vaccines because, they felt that their own people mattered the most. But I think the last thing I'm going to say about this is also for the global community to realize that when it comes to infectious diseases, there are no borders. It doesn't matter how much you police your borders. Infectious diseases would always find a way to cross over. And that is why, we need to really look at this as a global community. We are strong as our weakest link. And bearing that in mind, I think is really going to help us advance health equity for everyone, ultimately.
Thank you, Ifeanyi. It's been really lovely to talk to you, and thank you for reminding us really clearly that to achieve equity in healthcare, we have to achieve equity in health education, and reminding us of the role that everyone has to play in that, whether they're in the global north or the global south, in terms of holding each other to account and amplifying the voices of those change makers at the local level. And I think you've highlighted the really useful tools that we have available to us in tackling misinformation, particularly social media, but also using more kind of historical technologies like the radio and community meetings and things that really can drive change and shape trust within health systems. So thank you very much. You've been a great guest, and I've really learnt a lot from talking to you. And please do continue to share your experiences that you've had at LSTM and keep doing the great work that you're doing. Thank you.
Awesome. Thank you. Thank you so much for having me.